Thank you very much again. I've got a rather ambitious task to cover the whole of the aortic arch and descending aorta, and I'm not sure how far we'll get through, but we'll see how we go. So the two areas that I'm hoping to cover would be aortic arch repair and acute type A aortic dissection management, both of which are currently topical and both of which we've been lucky enough to contribute to in the world literature. So the peculiarities of the arch as opposed to any other part of the aorta is that not only do you have to look after the very important run-off vessels from them, i.e. the cerebral blood flow, but also the whole cardiac output goes past them, and you need to look after the lower part of the body as well. The very primitive approaches that were used for this way back when in 1955 by Denton Cooley was to use a complicated set of grafts to bypass and deliver flow to various parts while resecting the aneurysm, and needless to say that that was very difficult, and the outlook was poor from this, and it didn't take off. And then shortly thereafter they discovered the use of the bypass machine and made use of that to deliver surprise, surprise, antegrade cerebral perfusion, which we've rediscovered again more recently. The problem that they had in those days was that bypass machines were so primitive that the complication rate was high, and they had a stroke rate of at least 25%. But that wasn't the methodology, it was the equipment. So nothing was done much until this report from Hans Borst from Germany of the use of deep hypothermia and circulatory arrest, which of course had been used in paediatric surgery for some time before, but he made use of this to repair, successfully repair an arch fistula. And then Randall Group described another 4 patients, and thereafter deep hypothermia became well accepted into the field of arch repair. And really it's conceptually a beautiful technique, because you can, after cooling the patient down, you can turn off and remove all the blood, and you get all the advantages of operating on a cadaver, and there's no interference from anything, so it's very nice. The only problem is, well, as I say, advantages are that it's a bloodless field and there's no instruments in the way. And the philosophy that this works on is the slowing of the metabolic rate. So this is data from actual real patients on the enzymatic rates in the brain, and you can see that compared to a body temperature where you've got about 10 minutes before you get permanent damage, you can theoretically spread that time up to 40 minutes at 10 degrees. The trouble is, though, that while looking at patients in a gross fashion, and as surgeons would, are they able to walk or talk, if you do some finer measurements of their higher mental functions, periods of as short as 25 minutes can be demonstrated to alter fine motor skills and memory. And the not too infrequent situation what you used to see in this technique would be patients waking up in a dazed state and remaining like this for 2 or 3 days after surgery before they turned on again, and that was thought to be a benign condition, but it's actually not that benign, and has led to serious problems in the long term. The disadvantages then for deep hypothermia is that you've really got limited time to do it. You've got to restrict to, in theory, less than 25 minutes, which means that you can't really do a proper complex arch repair. And for various other reasons, it can be an issue, particularly prolongation of bypass and development of coagulopathy. So people have thought about how can we improve this, and Japanese came up with this technique of retrograde cerebral perfusion, and that was based on the finding by Mills and Oshner back in 1980 that patients who had accidental pumping of massive amounts of air through pump disasters during routine surgery were able to be saved by reversing the plumbing and pumping the blood from the venous side and extracting the air in that fashion. And so this method was then used to pump blood retrogradely from the SVC and in the hope that it would perform the same function that a retrograde cardiopulmonary catheter, for example, would do in protecting the heart. And the advantage of this are great in that here you are, you're providing some nutritive blood flow, so you can prolong the period of circulatory arrest. It's simple, doesn't add any or minimal cannula to the field, and it can hopefully flush out debris and air and maintain temperature. There's only one problem, and that's the blood doesn't get there. Out of 100 mils of blood perfused from the SVC, only 0.01% actually gets to the capillaries of the brain. So, in effect, it's useless in terms of nutritive function. And does it really flush out debris? Well, the answer is yes, but you've got to drive the pressure so high that you end up with cerebral edema, so that's a negative effect. So its biggest disadvantage is a false sense of security. If it's going to be used, it's going to be mainly to maintain some cerebral cooling and avoid air embolism in relatively short operations like a hemiarch replacement. So the logical thing is to go back to antegrade cerebral perfusion, and this was resuscitated again by Dr. Kazui, again, Japanese surgeons, with very good results. 1% stroke in his field, but still significant operative mortality. And the principle's simple. You put some perfusion cannulas into the head vessels and supply them from the pump and work around them as you repair the arch. And indeed, you can show that the mortality is a lot better with the provision of antegrade perfusion. It goes down from 15 to 8.5. But surprisingly, the stroke rate is not significantly altered. And you would wonder why that would be the case. But the reason is that introducing those cannula into the branches is not a benign procedure, and you can carry debris and air with those cannulas, or you can selectively, in error, supply a branch, such as the subclavian versus the carotid in the Innominate's case. And you still need periods of circulatory arrest before and after, so you're not completely doing away with circulatory arrest. And all the time the distal organs are not being perfused, so that you've got to have a heavy reliance on deep hypothermia. So deep hypothermia has got obviously the advantage of organ protection, but it's got a lot of disadvantages, not the least of which is coagulopathy. A very clever technique came along of using auxiliary cannulation as the main inflow for bypass, and then when the patient was cooled down sufficiently, the clamps were applied to the bases of the head vessels, and the rest of the arch was then decompressed, and you could work on it, and in the comfort that you're supplying blood to the ipsilateral brain and hopefully across the other side through the circle of Willis. But then objections came along, and that anatomically 15% of patients don't have good continuity between the two sides, and probably functionally a higher proportion than that don't have communication. So that technique was criticised, but in fact series have demonstrated that both the mortality and the stroke rate from unilateral perfusion, that's what is called unilateral perfusion, is no different than bilateral perfusion. And you might wonder why that is the case. And the difference is that this focusing on the circle of Willis is a little bit out of place. It's true that when you're doing a carotid endarterectomy, you're isolating the internal and external carotid arteries, and your only source of supply to that side of the brain is the circle of Willis. But when you're dealing with the arch branches, you've got a multitudinous of collaterals that are coming across from one side of the body to the other, particularly across richly collateralized organs like the tongue and the thyroid, so that you're not relying on the circle of Willis. In fact, most of your collateral network is outside of the circle of Willis. So then, if that is the case, why isn't unilateral perfusion superior? And the reason for that is, I think, that there's reliance on those collaterals for a very long time for the whole repair. And that's when things could go wrong in terms of hypoperfusion, giving extra perfusion or underdoing it. And the fact that you're only putting in blood supply into one out of the three potential collateral networks. And there are also other shortcomings to current techniques. If we're worried about the blood supply to the arch vessels, why are we doing the whole arch procedure first and then supplying the branches? We tend to ignore the distal organs completely. The myocardium is out of circuit for the whole duration of the repair, and in the end we end up with anastomoses that are buried deep in the chest and hard to access. And so there's been an evolution in how to reconstruct the arch branches. Initially using the island technique, which had the convenience of being a single suture line, and you still retained the native branching process, so there was little risk of kinking and distortion. But the problem was that island patch was often heavily diseased, either by dissection or atheroma, and once you'd pressurised everything, it was a suture line that was very hard to access. So then people moved into the pre-made branch grafts, which then allowed you to make the anastomoses to the specific branches into potentially healthier tissues, and also in areas that are more accessible after a patient was weaned from bypass. And also, you've seen this before, a pre-made branch graft, so that you could have a modular system. You can supply the branches directly off the pump through a three-way system, not having to wait till the whole arch is done. And then a further modification of using the elephant trunk technique, where a redundant piece of graft is placed within the aorta. Even though it's not sutured to the aorta distally, it's left free-floating. And then this could be captured later on through an endovascular procedure, and avoiding this delicate area of the recurrent laryngeal nerve. Of course, what's available to us now is a whole range of intraoperative monitoring, forms of EEG, particularly, and transcranial Doppler, and more recently the near-infrared spectroscopy to allow us to measure the adequacy of perfusion. And all this led us to our preferred technique, what we've labelled the branch first technique, whereby we use dual supply, or we started doing dual this way with axillary and femoral. More recently we've omitted the axillary approach. And using individual single vessel clamping, we can then replace the branches using a trifurcation system. So when we start off with the Innominate, of course everything's being supplied, there's nothing out of circuit. All the distal organs are perfused and the heart's still perfused and beating, and so we can comfortably replace that branch and keep it flowing. Once that's done, then the carotid is clamped and reconstructed, and this typically can be done in a very short clamp time, usually less than 10 minutes, which is even shorter time than it would take to do a carotid endarterectomy. And then finally the subclavian can be done in a more relaxed fashion. And once that's all done off the trifurcation system, it's able to be laid outside the field, so that the arch is totally accessible. And at this point the descending can be clamped, and this is really the first time that the heart is excluded from the circulation. And if it's difficult to clamp the aorta, then we can use intraluminal occlusion and perfusion techniques. Once that's all done, the completion of the anastomosis distally is done, we can switch the cannula from the groin to the side arm in the graft and perfuse the body in an antegrade fashion. And then finally the reconstruction to the aortic root, whatever needs to be done there, and then the common stem of the trifurcation is anastomosed to the new ascending aorta, again without interrupting any of the blood flow. So we got rid of circulatory arrest. And we only clamp one branch at a time. We do this for a very short period of time, typically less than 10 minutes. we have all these other modalities to help us with maintaining protection. We also use the prefabricated trifurcation graft to make the anastomosis into better tissues and more easily reachable for hemostasis. We've reconstructed in a pattern from innominate to left subclavian, which is more logical. You go from the superficial to the deep rather than the other way around. And we use a dedicated head pump so that we can vary the circuit, how much we supply to the upper circuit versus the lower circuit at any time safely. So our clinical experience up to last year, 64 cases, various risk factors. 25% have had previous heart surgery. Over a third were urgent, and about a half had type A dissection. A large number that required concomitant aortic root procedures, and about a quarter also required elephant trunk, further extension to the descending. We had an overall mortality of 3%. All occurred in acute type A dissections with pre-existing malperfusion syndromes, none in elective cases. Our stroke rate permanent was 1.5, and this was in a patient that already had neurological deficit from a dissection, and there were 2 temporary. The impressive thing was the blood use. Of course, patients still need blood products, but about a quarter don't need any red cells, and 15% didn't need any platelets or factors as well, and that included 2 redo patients. The other thing that's interesting is our intensive care doctors often comment that they wake up like routine surgery, and they're extubated in a more rapid fashion. So, in conclusion, our branched first aortic arch repair is a safe procedure. It's got a low morbidity, a low mortality, and a low cerebral morbidity. It's very hemostatic, and it results in better organ protection, and thus the surgeon can complete the repair in an unhurried fashion, and hopefully in a better fashion. I'm not sure how I'm going for time here. How am I going for time there? I don't know whether I can skip through quickly to dissection. Of course, acute type A dissection we know is a lethal disease and has a mortality of about 1% per hour through either free rupture, tamponade, coronary occlusion or AI. And the standard repair, of course, is to replace the ascending aorta and resuspend the aortic valve and get out of there with a live patient. But if we look at the long-term outcome, it's not a happy one for dissection, and there's a continuous drop-off as time goes on. But interestingly, that drop-off varies according to whether patients end up with a patent false lumen distally or whether it's occluded. And when the false lumen stays open, we end up with these nasty patients with complicated aneurysms, which mean difficult redo surgery, or difficult either via median sternotomy or thoracoabdominal, and potentially higher operative risks. So, and even if we do these through stent graft techniques, they're often very complicated. So it would be nice to be able to avoid that. And why is it that there is difference between a patent and a thrombosed lumen? It's because a patent lumen has a higher mean pressure in it. So the diastolic pressure in the false lumen is higher. So a greater part of the cycle, the false lumen experiences higher blood pressures, higher stresses, and so it tends to dilate over the course of time. And this can be demonstrated in MRI pictures. So the obvious extension then is, well, should we then replace the aortic arch routinely in this? And certainly in experienced centres, the operative mortality of doing this is no worse than doing an isolated ascending. But disappointingly, the outlook for the limited arch versus a total arch replacement is not as good as one might have hoped for. And so that led on to progression of replacing more of the aorta using the elephant trunk technique, whether it be a stent graft or a surgical elephant trunk. And the finding from these studies is that, sure enough, there's a very good thrombosis of the false lumen around the descending aorta, but unfortunately, starting from the lower part of the stent and downwards, the false lumen tends to remain and then create a more difficult situation to deal with later. And there may be many sources why the false lumen can maintain itself, but not the least of which are tears that are actually induced by the stent graft itself. I'll just skip over this. A very exciting development, which was pioneered by the St Vincent's group, is to use a covered stent graft in the upper descending aorta, and then use uncovered stent grafts going down all the way to the aortic bifurcation. And the hope there is to promote a true lumen patency, to improve its size so that there's good perfusion to the organs, and hopefully promote false lumen thrombosis. But unfortunately, this simple technique still left us with 75% of patent false lumen. And so then this group went on and described the STABILISE technique, whereby the uncovered portion was not only placed in the true lumen, but using a balloon catheter, it was forcibly dilated to the diameter of the overall aorta, such as to rupture the septum deliberately. And the philosophy behind it is to abolish this differential pressure that I was talking about before between the true and false lumen, and reoppose the layers and encourage primary healing. And their early results were not bad, but they found that they had to supplement this with a number of interventions. And basically the problem was that they retained the native arch. If they were doing it for type B, obviously the native arch was there, but if they were doing it for a post-operative type A, they hadn't replaced the arch at the time. And that's where the Achilles of this procedure was for them. And so we adopted the approach of using the complete arch replacement with the branch first, and added to it this technique, whereby we placed a stent graft that extended from the Dacron graft, and then supplemented this with the uncovered stent grafts all the way down the aorta, and then used a balloon catheter to forcibly expand it, and hopefully this plays. And you can see the balloon being, and then all of a sudden you get a pop through. And it's quite scary when you do it for the first time, but you can see the remaining wall stays open. And then often you will need to pay attention to the branches, and some branches will require supplementary stenting to make sure that they arise from the true lumen. And the reward, though, is that when you come back and do the CT scans on these patients, you get a truly unilamellar aorta and a prospect of having a patient that's completely cured. And we've got early experience with this in a variety of cases. At different intervals. We've tended to do these on the same admission, but sometimes that's not been possible, and some delayed cases have been done still even up to a year and 2 years afterwards with good effect. Early experience, procedural success has been good, one stroke, and the only recurrent aneurysm we've had has been in a Bentel's right coronary button. I think in the interest of time, I might leave it at that. Thank you.